Thank you for this opportunity to speak here. And basically, ROP is one of the leading causes of childhood blindness worldwide. It's now becoming a major public health concern in India. Over 50,000 children today are blind from ROP. That's a huge number. And in India, the incidence varies between 38 to 52% in low birth weight infants. And this is a potentially preventable, very tragic, needless cause of blindness. So what is the rationale for anti-VEGF therapy? First of all, lasers, the current gold standard from ETROP, unfortunately does not rule out poor outcomes in the more virulent forms of ROP. The shortcomings of laser, as we know, visual field loss, high refractive errors, especially in the zone 1 disease. It's difficult to do in hazy cornea lens, which is haze, with severe POCI ROP, AP-ROP, small pupils. It's slower to regress very severe pathology, and I dare say it requires more skill. And this is probably one area where you need some post-fellowship experience. The strengths of anti-VEGF on the other hand, not tissue destructive, therefore less visual field defects, refractive errors, continued normal retinal vascularization is possible in severe POCI ROP, AP-ROP, small pupils and hazy media. A more rapid response to an aggressive ROP where you need a rapid response and easier to administer. Now this graphic from beta ROP kind of puts everything together. You know, you have the phase 1, 22 to 30 weeks, phase 2, 31 to 44 weeks. Phase 1 has increased oxygen, decreased VEGF, and phase 2 is where there's a relative hypoxia with increase of VEGF, which takes the neovascularization forward. Now you can see those different stages out there, and if it's not treated, at this point you will get these tractional complications, and you can see with the ablative therapies, cryo and laser, you get the lack of vascularization beyond that point, whereas with Avastin or bevacizumab you get this going forwards. Now when there is an imbalance of VEGF, as you can see in this cartoon, what happens is there's disorganized angiogenesis and there's vessel dilatation as well as elongation. Now the timing of anti-VEGF is also important. If it's too early, it may interfere with necessary retinal vascularization. If it's too late, it may accelerate the cicatricial phase or cause a crunch and lead to early retinal detachment. So it's important to know when to strike. The common indications, AP-ROP is basically POCI location, prominence of plus disease, flat neovascular proliferation, vascular loops, and AV shunts, seen mainly in the zone 1 and zone 2, mandates immediate and aggressive management. In the Western world, small infants, low birth weight, but as the PGI study showed us, it can happen even in higher birth weight, more mature babies in our country. Plus disease is also an indication. Now the beta ROP trial, which basically ushered in a new dawn in the management of classic POCI ROP and AP-ROP, basically a prospective controlled multicenter trial, looked at intravitreal bevacizumab monotherapy of zone 1 and zone 2 posterior stage 3 plus ROP. Patients were randomized to 0.625 milligram bevacizumab or laser, and the primary ocular outcome was recurrence of ROP requiring retreatment at less than 54 weeks. Of the 150 infants, 143 made it to the 54-week timeline. 7 of them died, were not included in the analysis primarily. And the results. Now ROP record in 4 infants, or 6 out of 140, or 4% of eyes, which was way lesser than with the erstwhile laser, where there was 22%, 19 infants, 30 out of 146 eyes, statistically significant. And a significant treatment effect for bevacizumab, therefore, was found for zone 1 ROP, but not for zone 2 ROP. And this classic iconic picture from the beta ROP shows very clearly that with the laser you can see how this entire posterior area is ablated, and this patient is definitely going to have persistent visual field loss, whereas a more aggressive form of ROP around the same time, 2 to 3 months, when injected, this beautiful revascularization you can see at the same time point, 13 months. So that in light the advantage of Avastin. So intravitreal bevacizumab, in conclusion, as compared with the conventional laser in infants with stage 3 plus ROP, showed a significant benefit for zone 1 but not zone 2 disease. On the other hand, Huang's 5-year retrospective study showed very clearly, looking at 54 eyes with type 1 ROP, 22 eyes receiving Avastin, 32 eyes receiving PRP, showed results were that in the Avastin, regression was much faster in 48 hours, whereas lasers 1 to 2 weeks. In the meantime, from initial treatment to reach zone 3 was 5.5 months with Avastin, and the opposite was seen here, although it was a retrospective study, that 3 or 14% of the 22 treated eyes ROP record, which was much more than in the PRP treated eyes with 3%, which is why most of the experts here prefer to, if they can do PRP, they would still go first with PRP. So this is a case of post-laser eye and post-bevacizumab. As you can see the vascularization happening. Now, what are the issues with anti-VEGF? We talked of the good parts, but there are safety issues. There is morbidity, neurodevelopmental issues are there, mortality, late recurrences can happen, structural abnormalities have been seen, and there is dose variability. Now, mortality issues. In the BEAT ROP study, 5 out of 7 bevacizumab and 2 out of 7 laser patients died. But Helen Mintzner came out very strongly to say that mortality comes up in editorials. It seems that a lot of people can count a lot better than they can read. But I want to point out that 3 of the Avastin patients had non-Avastin related deaths. Basically, if you remove those 3, it's 2 out of 7 now, both the groups, and it's pretty similar. On the other hand, the same, following up about neurodevelopmental issues from the same group, Beta ROP group, Kennedy et al. Showed in their study with about, they followed up the patients, of these 18 patients, there were no significant differences between bevacizumab and laser therapy in terms of weight, length, head circumference, cerebral palsy, or Bailey scores. And they showed no adverse effect from both the groups on medical or neurodevelopmental outcomes. Basically gave it a safe, clean chit. But a more recent one from Morin et al. Neurodevelopmental outcomes following this thing, looking at 125 patient infants, 27 Avastin, 98 laser. It was retrospective. And they looked at neurodevelopmental outcomes at 18 months. Results showed median motor scores were lower in infants who had received bevacizumab, and the odds of severe neurodevelopmental disability in terms of cerebral palsy, hearing aids, blindness was 3.1 times higher for patients treated with bevacizumab. So there's still a big cloud over Avastin. It's not as rosy as it is sometimes made to be by some. Recurrence issues. Now, the time to recurrence from the BEAT was significantly different. Bevacizumab 16 plus minus 4.56 weeks, much longer than laser, which is 6.2 plus minus 5.7. So recurrences, this was noted by Darius Moshfeghi in his editorial, would have occurred even after the primary endpoint of the study. And Muller and Salcho in their study suggested that recurrences after IVEV treatment may occur in about 12% of cases, 12 to 15 weeks after the first treatment during prolonged. So you have to wait long. You can have late surprises with Avastin. Structural abnormalities can happen in the periphery. You can see peripheral avascular areas, abnormal loops, tufts and hypovascular areas, and AV shunts. And can also be seen in the center. You see a bevacizumab treated patient, there's no real FAZ here, whereas with a laser treated patient, the FAZ is formed well. And you can also have some wild, strange abnormalities like this abnormal pigmentary dystrophy. Dosing issues, bevacizumab half-life is still not very well understood in premature infants, and the wide variability in axial length can lead to variable dosing. This table from corner very beautifully shows that with increasing axial length, you see the concentrations keep decreasing in the vitreous. So it's a little obfuscated there. And different studies have used different doses, of course, with good results, but there is that variability in literature. The Cochrane review brought out by our friends in Ames is the last word. It showed reasonably good strength of evidence for anti-VEGF, bevacizumab, ranibizumab monotherapy in terms of reducing risk of refractive errors, significantly reduced risk of recurrence in zone 1 ROP, increased risk of recurrence in zone 2 ROP. They didn't find great strength of evidence, low quality strength for other issues like RD, mortality, corneal lens, no differences in perioperative retinal hemorrhages. So finally, take-home messages, gold standard management is still laser photocoagulation, has its own limitations as we understand, myopia, peripheral field constriction, macular dragging, hazy media, anti-VEGF may be used as primary therapy in AP-ROP, severe zone 1 posterior ROP. Adjuvant role, laser may be used as adjuvant in the above when residual peripheral avascularity persists. When you suspect non-compliance for follow-up, the child may not come back. Suboptimal response with anti-VEGF, that neovascularization stays there, then you might put in, and with peripheral 360 degrees of avascular, you might put in some laser there. But remember that use of anti-VEGF should warrant long-term follow-up of babies and watchfulness for side effects. Additionally, vigilance, as I showed, for peculiar peripheral as well as central vascular abnormalities, avascularity, is needed. Thank you.